Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Back with you here in the Dolph Simons Family Studio, broadcasting live. We've got some great guests. Of course, Hawkeye hardly counts as a guest anymore. Probably never really did. He's the right-hand guy here, Medical Director of Infection Prevention and Control. We do have two very special guests with us, though. Let's start with David Wild, VP of Performance Improvement. We're welcome to have David back on our program today. David is kind of our numbers guy, and he's going to help us go through some of the death statistics here at the University of Kansas Health System. That's not something we really love to talk about, but I think we need to talk about that today, and we're going to get into that a little bit, along with Erin Corvo. Erin Corvo is a Deputy Medical Officer at Wyandotte County. Delighted to have Erin back on our program with us today. She'll address more of the things from going on in the county, David here more in the health system, and Dane and I will continue to make up things as we go along. Of course, that's not really what we do.
It's a lot
because
of reading.
We don't make up numbers. We do tell the truth, and we stick to the truth religiously, because that's the thing that will help make sure that we all stay connected and we all understand what's really going on. So you're not going to see arm waving. You're not going to see us flap our arms. We're not going to talk in extremes. We're just going to tell you the truth about what's going on out there. So how are we today?
Be frank about it. We're doing okay. Not as good as we would like, but a lot better than last week. So we're at 28 patients in the hospital. 11 of those are in the ICU, and 6 of those are on the ventilator. And remember last week we had talked about, well, what about people that have recovered? Are we not counting those? We aren't counting those in our acute numbers, and that is consistent from what we've been doing since day one. But we still have 25 other people in the hospital who meet our criteria, or the KDHE or the CDC criteria, for being able to get back into society, if you will. Not recovered, but people we aren't counting. So there are still a lot of people in the hospital with that, and 3 of those are still on the ventilator. And we've talked before about, if you do go on the ventilator, it can take some time to come off, and that is kind of what we're seeing in those patients.
So the reality is we have 28 plus 25, was that the number?
Yep.
And so that puts us around 53. And the difference between those two numbers is that within the first 10 days, you're considered, that's when you have COVID. And after that, you're not as infectious. And so theoretically, we stop counting you on the first number.
Right.
That's how we've done it since the day we started.
Right.
People report their numbers a little bit differently, and it can be a little bit confusing. And I know that drives us a little crazy, David.
And part of that is also so that we can continue to have adequate PPE stores.
Right. The way that the genesis of that is, theoretically, you're in PPE for the first 10 days. After that, you could come out, and so the government doesn't allocate it. Also doesn't allocate remdesivir without those. They want to know those first 10-day numbers. So that's the number we've reported since day one.
Correct. Yeah. Our numbers, as we report them, and as you two have reported here on the show, follow the federal government standards for reporting currently infectious in isolation patients in the hospital, not total COVID patients in the hospital.
Total COVID patients is 53, and total ventilator with COVID is 6 plus 3, so it'd be 9. So, you know, it's a bigger number, and that's been true all along. But again, we haven't given that number because they're not acute infectious, and that's how we present it to the government. So, all right. So, David, how are things out there from your perspective?
Well, I think, Dana talked a little bit about where we are here in the hospital. I think the numbers over the weekend in the community were sort of what we've expected. So, more of this current plateau type of thing. I suppose for everyone's benefit, I brought pictures this morning. And okay, we'll start here. This is I brought pictures to talk about what we see in our hospital, and so there are a lot of numbers here, and I'm going to walk you through. The first couple of slides are comparisons, and I'll make some highlights here, key points. So this is looking at the self-reported race or ethnicity of the patients who have presented to our health system. The top, the larger of the 4 graphs on this slide is all patients. So whether they came to the hospital and needed admitted, whether they were just in a clinic, whether they were being screened for surgery, or whether they hit the emergency department. Everyone who tested positive. In the months of March and April, early in the pandemic, you'll see the largest on that top graph, the largest proportion of the population that we saw was African American, 41.5%. Followed then by Caucasian at 32%. And the other, as you see on these slides, is primarily Hispanic or Latino. And that was the sort of all patients presenting. I said, and the next few slides will look similar, so I'll walk through this one maybe in more detail at first. So on the bottom, the left-hand side, is the race or ethnicity self-reported for those patients who needed inpatient care, who needed to be in the hospital. And here it was about the same, 41.5% African American, 33% Caucasian, and then decreasing from there. Outpatients looked a little bit different, 41% white or Caucasian, followed by about 19 or 20% African American. And then in the emergency department, it was predominantly, again, or the largest population, I should say, was black or African American.
And
so that's April.
And why do we think if we tested more Caucasians in the hospital, we had more African Americans?
Well, I think part of that was due to the way the disease was spreading earlier on in the pandemic. I think also part of that is early on this appeared to be a very, very local disease, almost hyper-local, meaning for the first few months, 90 some odd, 97, 98, maybe even a little higher percent of the patients that needed hospitalized that we saw were from Wyandotte County. And that's very different from our normal patient population, which is predominantly spread out across the state and the metro and even across the country. And that doesn't happen with COVID. Now, that has changed a little bit as we look at current. So if we switch from March and April, let's look at the same look, patients by race, on the next slide, which will be July and August. So recently, here you see, instead of the predominant group in the total population being black or African American, it's now the other, or the Hispanic and Latino, 38% in the total patient population. And the same is true if we look down in the inpatients. We flipped. About 35% of the inpatients now being that other group, or Hispanic and Latino. And while this may look a little bit more like the population makeup for Wyandotte County, it's still disproportionately involving in the inpatient space both the African American and the Latino population. And then the others, as you look across the outpatients in the emergency department, the shift is sort of the same. Now, you'll see here in the outpatients, there's a large percentage of blanks for race. That's because new patients who come through our outpatient testing clinic who've never been registered before are not being asked about their race. So that's a little bit of a confounding variable in the outpatients. But you see the inpatient and the emergency department patients give us a good picture.
Okay.
So that's sort of race or ethnicity. If we move to the next slide, we'll talk a little bit about, okay, well, we'll talk about this first. So this is actually back to the question or comments about how many patients are needing hospitalized. So the number that we share here on the program, and we share publicly daily, for patients in the hospital is a census number. It's the number of patients in beds at midnight on any given day, or 9 a.m. as we use or 6 a.m. I guess for the show is the number Dana's using. In any event, it's the same time every day. It's the number of patients here. It's not the number of patients needing hospitalized or the number of new patients coming and presenting needing care. And this is that graph. So the top here is the number of patients on any given day that need hospitalized. The bottom is the number that are discharged. And this starts to give you the balance of why we stay at about 28 or 29. Because our number of patients that we're admitting every day is increasing, but our number of patients that we discharge on any given day is increasing about the same. So that helps make out the census. But that census number only tells part of the story then. It's really important here to recognize that really starting in mid-July, we have been at the peak in the entire pandemic in the number of new patients every day that are needing to be in the hospital in our system. That speaks volumes about transmission in the community when we say we know that if there are more cases, there will be more hospitalizations. More hospitalizations lead to more deaths. This is really the picture, I think. If I wanted to share anything with the community, it's that there are more people getting ill. There are more people needing to come to the hospital. There are more people having an impact on the healthcare delivery system, even if that census number looks the same. So people can say, well, why your census number is the same or down? Yep. Why do you tell us it's getting worse? Here's the reason, right? Right here. Probably the best message for everyone to take home from the entire deck of slides is that more people now are hitting the hospital every day, new people, than were even in April at the previous sort of peak in our surge. If we move to the next slide, this is going to be more of the, okay.
Our order may be different.
Our order is different, yeah, which is fine.
It'll be a surprise every slide, right?
This is good because this tells a story too, a slightly different story. We'll get to age, but this is actually telling the story of comorbid conditions. So one of the questions I get all the time is, are the patients that are in the hospital or that are needing to be hospitalized sick? And if so, right, they have lots of bad diseases, right, coming into this. So this is actually looking at the same comparison. The blue bars here, March and April. Hospitalized patients only. The sort of red or magenta bars are July and August, hospitalized patients only. So there are a couple of things that stand out, and I'm actually going to start with the far right bar. If you can't read it, the far right is the percentage of patients with no, or proportion in this case, is the y-axis. The proportion of patients with no coexisting disease. In March and April, the blue bar, it was about maybe 5 or 6%. Let's say right at 6%. In July and August, it is at 17.5, nearly 18%. Yep. 3 times more patients in the hospital now with no coexisting disease when they hit the door. 3 times. And so that's basically 1 in 5. 20% of those hitting the hospital have no disease prior to showing up.
Besides COVID.
Which is very, very different from March and April. Huge difference. But if we then do say, okay, for those that have, for the 80% that now have coexisting conditions, what are the things that we see most likely? So hypertension is by far the most common. It's still present in about half of the patients. Hyperlipidemia, so high cholesterol, another very common chronic disease across the community. And then chronic kidney disease. So I think that goes along with hypertension, but we see the impact of that in inpatients, especially those that end up very sick. The risk of sort of the clotting and the kidney disease that are associated with COVID impacting someone who's already had kidney disease can push them over to the point of needing dialysis rather quickly. And we saw that a lot early on in the disease and some in those that are really critically ill today. And then from there, there's a scattering of other things. Diabetes also tends to go with hypertension and hyperlipidemia. That's a sort of a triad. The renal failure fits with both of those as well, as does the anemia. So those with chronic renal disease are more likely to have anemia and obesity. And from there, it sort of trickles down into a number of other things. But that part about the 3 times the portion of the population being admitted now not having coexisting disease, I think is really important. For those that say, well, the people that end up in the hospital are just sick before they get there. Well, many are, but more and more every month are not. Mm-hmm. Yeah. On the next slide, then, I think the only thing that we've got left is talking about ages. So this is deaths. This gets into the death numbers. And so the same comparison, early in the pandemic, March and April, to now, late in the pandemic, July and August. I don't want to say late, current.
Yeah.
So early in the pandemic, those that died were primarily, you'll see here, between 60 and 89 years of age. If we move to the next slide, looking at July and August, you'll see now the age groups are very different. So while there are still a large number that are 60 or older, the 50 to 59 age group is there. And you'll see there are deaths in the 20 to 29 age group and the 40 to 49 age group.
What happened to the 30 to 39?
Yeah.
We just got lucky so far in that age group.
For whatever reason, we've not had a 30 to 39.
I wish I was that age group. I am not that age group.
I am for a few more days.
Yeah, hours maybe.
So that sort of tells you the picture about deaths. You know, we said we would share a lot of information about the deaths and about the way that people are ending up there. This is sort of the first look at that there's a different population now than there was in March and April. In the hospital, there's a different population getting tested and testing positive, and there's a different population dying. And I think that is also a good message for the community that although the death numbers have not been huge, right? We're somewhere shy of 50 deaths total since the beginning. There's a real impact in that some of them are
young.
Yeah, less than 30.
And some of them didn't have a lot of underlying disease between 20 and 29 who we lost.
Yeah. And so these numbers aren't big the same way, right? Those 20 to 29 age groups are 1 or 2 people. It's not like there are a lot of people. Again, to try to be really clear, we're not trying to sensationalize here. This is just proof that there have been patients in our hospital that are younger that have died from COVID.
Yeah, if
and
I
there
do
are
the
patients
math, that would be like about 3%, or about 3 people like that. So, Aaron, as you look at this data, talk to us a little bit about how you think of Wyandotte County and how you think things are going for Wyandotte. And again, Aaron Corvo is the Deputy Medical Officer for Wyandotte County.
Sure. Thank you so much, Steve. And David, those were really very helpful statistics. You know, one of the things that I really wanted to talk about today is the fact that we're, continuing to see a pretty high percent positivity rate in Wyandotte County. And so what that means is for the people who come in,
And right now we lost you for some. Hey,
We're
Aaron.
coming through to be tested.
Hey, Aaron. Hey, Aaron.
Can't hear you. He's going to go check her audio.
Okay, we're having a little trouble with Aaron's audio, so before we go there, we're going to come back to Erin Corvo in just a moment because I want her to be able to talk about the Wyandotte County slides. But Dana, as you look at this, tell us about what you're seeing as you experience ranting on the floor, because you're up there. I'm going to be there this week. You were there almost every week, I think. And how is the disease changing, do you think, in terms of the people you're seeing with it?
Yeah, I've been on the floor for the last 4 weeks, so certainly seeing the COVID patients along with a lot of my colleagues and our hospitalists, Chris Brown and all that group. It is different. So certainly a lot more Hispanic, Latino patients, but also younger patients. And for my younger, we know that there is 1 or 2 up in the ICU who are very young, 30 to 39. But for my younger patients, they've been in the 40s. And they have come in, and luckily they have been able to be discharged earlier and haven't been in the ICU. But then I did have 1 or 2 patients who were in the ICU and who did not have a good outcome. But it certainly has changed. It does tend to be certainly more the minority populations, but also the younger. And some, even if you're young, it hasn't prevented them from not being critically ill and going to the ICU.
So as you think about that, as you reflect on what you're seeing up there, that's got to be hard because you're seeing younger people and some of them who didn't have all the same level of underlying disease as part of it you would hope to expect. And now we're seeing our college campuses reopen. And you and I were on some texts yesterday. David, you guys were on the phone call this morning. Kind of difficult things out there because we're seeing some young people, especially in sororities and fraternities, returning up positive. Man, that could portend badly for the campus. Yeah,
just some of the stories today about, just some of the young people maybe not recognizing they have new symptoms or symptoms of COVID. So at that point in time, they are extremely infectious, spreading to their colleagues and then going to get tests. And that is how you can see how the growth and the spread of this disease can be exponential, and especially in places where people are close together, college campuses, dorms, apartment buildings, fraternity houses.
Yet our overall positivity rate in Lawrence is still pretty low, I think. When we saw the cluster, but they think overall it's still around 1% of students being tested. That's good news. Okay, Aaron, you're back with us. Let's try again. We missed you, and you were saying something really important. You showed some Wyandotte County information. Let's try that again because I want folks to see that, to hear it. Because you had some.
Okay, am I back with you guys? Can you hear me? Okay. Actually, wondering if we could bring up some slides. I have a couple things to share with everybody from Wyandotte County. There we go. Thank you. I really just wanted to say a few things about how we're doing in Wyandotte today. I wanted to show you this. You can see here toward the right that in Wyandotte County, unfortunately, our rate of disease from COVID is actually really, really high. And in comparison to the state and other surrounding counties like Johnson County and KC-Mo, we're really getting hit pretty hard here. Next slide, please. I also wanted to let you all know that our new cases that we're identifying on a day-to-day basis are actually declining, which is a good thing. We've got our 7-day rolling averages here. You can see there in mid-July we really peaked, but now we're starting to come down. Next slide. One of the things that we're seeing here is that, again, our deaths just sort of have gone up a bit and are now coming back down. I appreciate everything that David said. We're cautiously optimistic, but we're watching this very, very carefully here. And of course, this is only Wyandotte cases now. And so David was mentioning all of the people in the KU hospital. Next. The next thing that I think is really important here is our percent positivity rate. So of the people who we test for COVID, we're seeing about a 19% positivity rate, and that's still really, really high. It's higher than we would expect, and you can see there that there's a small trend in the upward direction. This is actually really concerning to us. So whereas we're catching, fewer people coming through to be tested at the health department, still really high numbers of percent positivity rates. So one of the things we wonder about is, are fewer people coming in to get tested at this point? And that really is concerning to us. So if I could send one message, it's that, if you are feeling symptoms of COVID, or if you have been in contact with somebody who you know is positive, come get tested, because our numbers have really been down. But when we see this level of disease or this percent positivity rate, we think, I don't think that it's fewer people who have the disease. I think that it's fewer people who are probably coming through to get tested. Next slide, please. Just want to quickly say that we ask everyone who comes through the health department how they want to identify of those people who have come to get tested, and this is all our data through the pandemic together. Really high positivity rates in our Asian population, and then people identifying as other. Next slide. And most people in that category then identify as the Hispanic ethnicity, and we are seeing really high rates in Hispanic individuals and families, unfortunately. Next. I did also just want to go over a couple things for Wyandotte County, because there's been a lot of controversy about reopening schools, but we're going to reopen our schools at 50% density in any given building, and we're going to do that right after Labor Day. We actually feel pretty confident that we can achieve this. Each of the school districts in Wyandotte have submitted plans to us, and we at the health department have looked them over, and they're looking really great. A lot of strategies to keep students and staff and teachers safe, and so I just want to shout out to our educators. They have been such awesome partners in this. And the final slide that I want to show today is, there was a lot of controversy around this sports order. And unfortunately, we've decided not to allow any contact sports, but we just feel that the science really, really is backing this up. We cannot have our children playing football, soccer, volleyball, and people laugh and they say, what about band? Is that a contact sport? And no, of course not. But it is, a high risk of aerosolized particles with our wind and brass instruments and such. So we're not going to allow those this year. We are going to allow some sports, and the Kansas High School Athletic Association has some great mitigation strategies there that they've put out for our athletes to follow. And so we feel pretty confident that that's going to help keep our students safe. We're all sort of on a very and I just have to say that I understand this, as a former student athlete, but the larger team is our community, and I think that this is going to help keep everybody safer in that way. We also know that even our children are getting sick. And as David showed, we've got younger people coming into the hospital, which is really concerning. And we know that even though we're not seeing a lot of deaths in our children, which is so great, we are seeing that there's illness that lasts for a long time, and we just absolutely have to keep them safe, their families, their grandparents. So that's the decision we've made. I'm going to kick it back to you, Steve.
All right, Erin, thank you so much. Great information. Well, Jill, let's turn out there and see if there are questions from media to begin with. Not hearing any, so I bet we're going to have some from our listening audience today.
I think I'm going to go to Anil first. You may recall Anil. He's one of our patients that we've had on a couple of times. And he is asking, is there any tracking of what percentage of people who have long-term complications from COVID?
Great question, David. Let's talk to you and Dana. What do you think about that, long-term complications?
Yeah, so I think the reality is there just aren't the numbers to give us a great picture of people who have, I'll say, recovered 3, 4, 5 months out with the small number of people who are positive in March. So there's the beginning of some sort of national look for people in New York, and so there are some concerns about chronic lung disease, maybe a smaller percentage than some of the other issues of inflammation of the heart, which I know that you all have talked about in sports. There are probably some other issues with blood clots that may be medium to long term, and the risk of renal disease. And all those are beginning to be described in the literature. But as far as our own population, I don't think we have any great measurement at this point.
Dana, from your standpoint?
No, I know that sometimes in our post-hospitalization discharge plans, you can follow up with physicians. We know that those types of long-lasting or chronic sequelae or problems that occur after COVID are quite common. Things most common from patients that I've talked to are fatigue, just being tired, still some shortness of breath and cough. A lot of times, if people have loss of smell, that will tend to go away slowly. But we are looking that these symptoms can continue for 2 to 3 months after recovery from the acute illness.
Which really isn't that surprising if severe influenza can last 3 to 6 months. And what we've said before is if you've been really sick and you've been in the ICU,
Yes.
you may be 6 to 12-month recovery. This is not uncommon for critical illness of any sort, leave alone this one. And I don't know. Any other thoughts, Aaron, to that?
Interesting question. I think we need to get those data. And one of the reasons we made this big order for sports, in Wyandotte County is we're even concerned about our children having long-term consequences. And, there's some argument that maybe a kiddo who had COVID would maybe need an echocardiogram, before going back to sports play. And so, we're really concerned about this kind of stuff too, for sure.
It's an evolving story and it evolved even more over the weekend. So we'll try and take another look at sports here in the next week or two because I think it's going to be important for folks to hear as that story continues to evolve.
Sure. Evelina wants to know of the numbers that you gave of deaths, of the younger patients that have passed recently, she wanted to know if they had underlying health conditions.
So were the younger folks sick or were they just young people and got COVID and did poorly?
So I'd say it's a mix. There definitely have been in the under 40, the younger crowd, there have been patients that have had chronic diseases that impacted their care. There have also been 30-year-olds very, very sick or 30-year-olds that have died who really had no coexisting disease before coming into the hospital. Interestingly, there is some question about whether I'll say a sedentary lifestyle may be its own sort of risk factor. So even if you're not obese, if you're not active and don't exercise, are you at a higher risk? And I think, that's a very interesting question because I think that was postulated at least in one of the 30-year-olds who may have not had coexisting disease, but might have lived that more sedentary lifestyle, not been very active. So. It's really hard to answer very specifically. The numbers are small, and it's hard to know what that means. But I'd say a mix.
I do note that you just said under 40 is a younger crowd, which you're still in right now.
Yes, sir.
But not for much longer.
Yes.
You and Aaron both. Aaron, any comments about that? All three of you, actually, I may be in that crowd.
Sure about that. No, I think David covered it well. Again, just, we really can't let up in any age group. I think that we're seeing that this disease is very dangerous. We want to decrease chances of people who are school-aged, who are 20s, 30s, 40s. Without a doubt, those folks are also affected, and we just can't see, losing anybody in our county anymore, and again, mask wearing, and we know how to control the spread of this disease. And so I just want to give a shout out to the community. Again, remember that the dominant form of spread is, this particles from our mouth, from our nose, and so cover up with a mask. It's really important.
So important. We're going to talk more about that, I'm sure.
Cody with Channel 9 News just texted, and he wants to know from Dr. Koravu and the other doctors, why do you think people would be testing less now?
So, Aaron, why do you think folks are testing less now than they were?
It's a really good question, and we're trying to figure it out. And I think we're seeing this trend nationally, actually. I don't know. I'm guessing that people are exhausted by the pandemic, unfortunately. It is getting tiring. The other thing is that we have had a really hard time, because we've had so many cases, we've had a really hard time keeping up with our contact tracing. We're doing our due diligence to call people back, if they're positive or negative, but sometimes it's taking a few days. And I think when we lose a couple days there, it's really tough to catch those people who have been in contact with the positive cases, and then to encourage those people to come get tested. So I just want to say, if you know that you've been in touch or in contact for 10 minutes or more with someone who is a positive case, we really want to encourage you, if you live or work in Wyandotte, to come by the health department and get a test. And you might say, well, why is it even important? Well, it's important for us to keep track of where this disease is, how many people have it, and I think it helps the entire system. I'm guessing that it helps the hospital as well.
Yes, I think so. And we do want people to get that test for all the reasons you just outlined. It's incredibly important. Jill?
Jean and Sean want to know, when you say hypertension, if you're taking medication and it's controlled, is it still an underlying health risk?
Dana, what do you think? What the folks are seeing?
Yes, it is. Yeah. And great, get it controlled. That's important. We know hypertension can have long-term effects, just as you talked about, on your kidneys, things of that nature. So even if it is controlled, unfortunately, it is still considered a risk factor.
I want to pick up on something Aaron mentioned, and I think, there's the wearying of disease. I was on a Zoom call with family yesterday, and they wanted to talk about COVID. And I was like, let's talk about COVID, important thing to do. But all of us are getting weary about this, and it's not done yet. We may argue that we're past the midpoint, because hopefully we'll have vaccination and therapy by early spring, maybe even late winter, and that will be great. But I think we're all just a little weary of it. But we can't get weary, because the way to beat it is not by being tired of it and then refusing to follow the rules of infection control. Rather, it's to follow the rules of infection control will end the weariness. And I think that's how we have to look at that. We have to take the steps we know to do, whether it's socially distancing, gathering in small groups, gosh darn, wearing the mask, washing your hands, coughing your elbow, staying home when you're sick. I think those are the key things. And if you do feel sick, get tested so we can help identify those around you who need to isolate so they don't go make somebody else sick. So, that's really the message to us all. We can beat this disease. It is really not a powerful disease. What's powerful is what you can do to help change the outcomes. That's where the power lies.
Really good questions flying in. Noelle, I want to take this question. They were on Friday, and we're carrying it over to today. When looking at school reopening, wouldn't it make sense to exclude institutional cases such as nursing homes and weight more the cases in school-age children? They want to know if health departments could issue guidance district by district. So they're saying if in a nursing home, all the cases are kind of combined and you're not allowing visitors, why not just take them out and not count them as part of the community?
Yeah, well, they are part of the community, Aaron. You want to take that one? Nursing home?
We certainly know that a large number of our cases have been in our nursing homes and long-term care facilities. However, the people who work in those facilities, live in those communities and surrounding communities. With the question of kind of district by district, one thing that we know about this disease is that we're really all connected. Let's not forget that this started out, many, many miles away in China. Here we go. Here we've got it all over the world now. It's fascinating how this disease spreads, and so that's why we just can't wall off, very easily, long-term care facilities from schools, from whatnot. And I don't feel like we can do that in districts either. Sometimes we think, gosh, being a county health department is even difficult right now, and we do our due diligence to try and coordinate our efforts with other surrounding health departments in other jurisdictions.
Dan and I had the pleasure of hearing Dr. Deborah Burks over the weekend, and she was here on Saturday. She's on our campus, and she was with Wyandotte and Johnson County health officials, as well as members of the governor's office and state government, and then the Med Center, both a University and Health System side. And it was a great session. I thought she did a great job. She's like one of the smartest people
Very
you'll ever
smart.
meet, and you just think if the whole country would listen to Deborah Burks and Anthony Fauci, we would be so much better off. One of her points was that, and one of the sources of concern is that the heartland, Kansas, Missouri, Arkansas, Oklahoma, Iowa, Nebraska, is about to become the next Southeast, meaning Georgia, Alabama, Mississippi, Florida, South Carolina. And the reason is that the really dense spread, the really significant hotspots there have begun spreading this direction. And because we do have a lot of counties where mask ordinances are not in place, where people don't do a good job of masking, even in the counties where they are, where there's a lot of social gathering, we are at high risk for becoming a really major hotspot and seeing a rapid increase, including overwhelming of healthcare resources. And she said that's happening to you at the same time schools are opening and colleges are reopening. You have to be extra vigilant. And one of the points she made, and she spoke about it, and she's worked in HIV research all around the world. She was the head of the HIV pandemic response team for the United States and really for the world in many areas. She said very poor countries have been able to control the outbreak of HIV and now even coronavirus better than we have. And one of our challenges is because we have such a high regard for personal freedom and local ordinance and governance that we all are not acting the same. Yet we live in this tangled web of a community so that what happens in Jackson County, Missouri does influence what happens in Johnson County and vice versa. And that in turn affects Shawnee County, or name your county as you go west. And you're seeing this begin to really take off in rural areas throughout the United States, and that includes Kansas. Her answer was stricter than anything we're seeing. Mandatory mask wearing inside and out. Limiting the size of groups to 10 or more. No travel, except for key things like going to the grocery store, etc. Businesses are open, but in a very limited fashion. When you look at that, that's a much stronger response than what we have now. But she's saying we have to do this throughout the heartland and really throughout the country if we're truly going to control the spread of coronavirus. And I think what we have to remember is that is how we beat this disease. Yes, we have freedom. We also have responsibility. You can't drive down a street at 100 miles an hour. You can't light a building on fire. So those are things that you can't do even though we have freedom, because there's freedom with responsibility. Think about yourself as a match. How many people will you catch on fire? You don't want to burn the house down. So I think we have to remember freedom with responsibility helps us keep our liberty overall.
Madeline wants to know why we need to have, as CNN reports, 5 million tests a day and why asymptomatic people need to test.
All right, David, you want to take that one?
Good question.
Well, yeah, I'll start. I think everyone will probably chime in because there are a lot of reasons in
There
reality
are.
for that projection as far as the number of tests needed. So Aaron hit a bit on the first reason is the more we test, the better we understand the transmission dynamics of this disease. We know where the pockets are, whether they are symptomatic or asymptomatic, and we have a better chance of isolating those people who are positive and then a better chance of limiting the spread. The other sort of important reason from the statistical, the numbers lens, is that when we have a 19% positivity rate in Wyandotte County or a 9% positivity rate in Johnson County, we know that there are positive patients that we are missing, both symptomatic and asymptomatic. And so setting a threshold that says we test enough people to keep a positivity rate very low gives us the best shot at understanding and managing trends in the disease because we're testing a large enough population to have a good sense of what is actually happening. Right now we know we're testing a sliver of the population, and we're extrapolating a lot of answers from that. And sometimes those assumptions are spot on and sometimes they prove to not be the case as time bears out. And so the better, think of it this way, maybe the best way I can explain it. The higher the resolution on your digital camera, the better you understand the picture at hand. With a low resolution digital camera, less tests, right, is the comparison. You get a general idea of whether you're looking at a landscape or a picture of a person. But with a really high resolution digital camera, you understand a lot of specifics about what's happening in that picture. And that's the benefit of a higher testing target.
I have a lot of people that are saying it's taking so long to get the tests back. Is that a reason why is it a waste of money?
What do you think, Aaron? Is it taking a long time? Is that defeating the desire for people to get tested?
You know, it may be part of it. I am still proud to say that in Wyandotte County at the health department, we've been able to continue our turnaround of about 36 hours or so. And I know you guys have a great turnaround there at KU as well. I do know that there are some organizations that are struggling and that test turnaround times have really increased, unfortunately. And so we're always trying to sort of troubleshoot that. I know that there's a lot of fear out there also about this sort of deep nasopharyngeal swab test and how, you know, some folks find that to be really uncomfortable. Well, I don't know anybody who thinks it's comfortable, but, you know, we would hate to get that to be in the way of somebody coming for testing. And so we're trying at the health department to validate some type of saliva testing that would be much easier and maybe even able to do at home. And so we'll let everybody know when that comes to bear. But I think we're not far off from that sort of testing as well.
There's really been some encouraging news, and Dana, we're talking about that tomorrow on our program as we talk about salival testing and the role of that going forward, because there's some pretty interesting developments in that area.
Yeah, we would certainly love to have all testing available for everybody almost every day. With that knowledge, you can really get a handle on what the infection dynamics are within your community, maybe within your family, or even your bubble. So if we can get the daily testing and it's feasible and it's efficient and you can get good results, then we would certainly want that more, because by knowing that, just as David had said, we are able to hopefully then even lessen the spread of the disease as much as possible.
All right, time for one more question, Jill.
All right, Brian is in the Park Hill School District, and he said over there they have the buildings open at 50%, but classrooms are going to be at 100% because they don't have enough teachers. Is that effective?
Ouch! Oh man. Okay. All right, Aaron, public health expert. What do you think? That doesn't sound. That's giving me a little bit of nerves.
Yeah, my tummy's feeling upset about that, but I guess the point that I want to make is that really it's about how you spread yourself out within a school. So not enough teachers is definitely a tough one. We've asked school districts to consider, though, thinking about the density of students. And so, you know, getting that to be at about 50% is our goal. And so what I mean by that is having class in sort of non-traditional spaces, for instance, like in the gymnasium or other larger rooms where maybe previously there would have been music practice or band or something like that, so that you can space the students. We are just really grateful for our teachers and what they do every single day. There's so much sacrifice, and I know this is a really difficult time for them. So I wish you good luck, and we're open at the health department in Wyandotte if you need any specific one-on-one sort of consultation.
Yeah, that's a tough statistic there, David. Final thoughts.
Yeah. I think, you know, maybe I'll just use that to jump off. We've said over and over, and just in about every venue, that the risk of transmission of this disease is a combination of duration and intensity. And so even in that school question, right, the shorter amount of time that you can be in close contact with others and the intensity, right, the masking is a benefit to reduce that intensity. And then, of course, you have the other issue of just simple probability. If you're in a group of 10, you're much less likely to come into contact with a positive. So than if you were in a group of 20, double the size. And so that conversation around classroom density is really important, because if your bubble is smaller, if it's 10 people, you are much less likely to come into contact than someone, or than with a positive patient than if you were in a group of 20. And I think all of those things, I mean, they're simple. They're just not easy to do. They're simple constructs, easy to understand, hard to implement. Teachers being a limiting factor in this case. But I think we all owe it to ourselves to consider both those concepts, intensity and duration, and as small as bubble as possible.
Yeah, and I just think, man, you're going to the schools are open at half, but the classroom's 100%.
Yeah.
I don't know I'm not sure I understand the math of that.
Yeah, again, I would, if you have to be in that situation, you can protect yourself as much as possible, wearing the mask, perhaps even wearing a face shield or goggles or eye protection. I don't know exactly what the teaching situations are now. I think it's different than when I was in school as far as a teacher sitting up at a blackboard or a whiteboard and doing the lesson. But if you can keep that space from those students as much as possible, unless you need to say help them with comprehension or doing a problem, decreasing that amount of time in that close proximity as much as possible. And again, having everybody in that classroom wear the mask also.
Today's discussion has been a little sobering, right? We spoke about death, and we spoke about who all's getting sick, and we heard stories from Wyandotte, not stories, we heard what's going on in Wyandotte and here in our health system. And I want to thank Aaron Corvo, the Deputy Medical Officer for Wyandotte County, and I want to thank David Wild, our Vice President of Performance Improvement. Hawkeye and I can't say that. Hawkeye and I are here every day trying to answer those questions and trying to continue to tell the story. And tomorrow we tell the story some more. We're going to talk further about testing and really focus on salival testing. Robert Thompson is the Chief Executive Officer of Clinical Reference Laboratory. They've teamed up with Chris Wilson and the University of Kansas Health System. Chris Wilson is our VP of System Integration and Innovation. He'll be in the studio with Dana and I. We're going to talk a lot about what's going on around testing and salival testing and how we've done this in Lawrence, because I think it's an important story that we should all hear. Boy, this has been a big conversation, and a lot of breadth and a lot of depth, and we showed a lot of slides. We don't typically do that, but we wanted to tell the truth about who's getting sick, who's dying, and what's really going on. We'll continue to try and do that. And remember, for you, you are the key. We've said before, coronavirus is not a superhero. You're the superhero, and you can beat it by doing the things we talk about doing every day. So don't be the match that starts the fire that burns the building down. All you have to do is wear a mask. Keep your distance, wash your hands. Don't go out if you're sick, cough into your elbow. We're going to finish with another sobering review. This is someone who works here in our health system, and as we sign off, we want you to hear some thoughts from one of our frontline nurses who has cared for patients who did not survive COVID-19. Let's take a listen.
Please wear a mask. This is no one is making this up. This is real. This is happening here. This is happening in our community right now. We need to get serious about this. In April, I cried probably after every shift. I lost 2 patients this week. It's been very, very difficult. The second patient, he had been with us for quite some time, and we loved him and we loved his family, and your heart just breaks for them. At the end of the day, me holding their hand and me, speaking to them is not the same as their wife, their son, their mother. It's not political anymore. This is just a matter of life and death, and it's a matter of survival. Wear your mask, stay home if you feel sick, and wash your hands. I mean, it's not difficult. It's really not difficult. Keep your family safe, keep your community safe, keep yourself safe.